Welcome to Editor's Choice, the podcast at EuroIntervention, where we highlight the latest science and research in interventional cardiology. I'm your host, Aaysha Cader, and through conversations with the authors, we explore study design, key findings, and their relevance in contemporary practice. I'm very pleased to be joined today by Professor Roxana Mehran from the Mount Sinai Hospital in New York, and we will be discussing the paper from their group titled Prevalence and Prognostic Impact of High Ischemic Risk Criteria in Chronic Coronary Syndrome Patients Undergoing PCI. Welcome to the podcast, Professor Mehran.
Thank you very much, Dr. Cader, and it is just wonderful to be with you, and thank you for having me and for featuring our paper.
Fantastic. Let's get down to the bottom of it. So in terms of background and rationale, what are high ischemic risk criteria in PCI, and why is it important to study this in CCS patients undergoing PCI?
Yeah, so thank you for that question. And that was truly the background and the rationale of our work in terms of the high ischemic risk patients, because we see them every day in our practices in the cath lab. And the ESC 2024 actually put together a high ischemic risk criteria with an aim to identify, especially patients with chronic coronary syndromes who remain at high risk for recurrent ischemic events. And of course, understanding this is very important because when you identify a high ischemic risk patient, that's the patient with a high events. And in those criteria that we have from the ESC 2024 was basically combining both clinical factors and procedural and anatomic factors to evaluate this. And those include diabetes and CKD. We know all the time they're associated with higher event rates, higher ischemic events, especially when you're performing PCI in the left main with a long stent length of greater than 60 millimeters or even a bifurcation PCI requiring 2 stents or more, and of course, chronic total occlusion. These are the features that identify those patients who are at high risk. So it's a combination of both clinical and anatomical factors. And identifying those patients helps us individualize what we're doing with our dual antiplatelet therapy and coming up with a unified or a uniform strategy that helps clinicians think about that in terms of the duration of dual antiplatelet therapies.
Fantastic. Thank you for explaining the rationale behind why these is an important risk criteria to study. In terms of the design, this was, of course, retrospective observational study at Mount Sinai Hospital. Could you detail for us the methodology and also its main endpoints?
Yeah, so I will say that obviously the methodology of this paper has its own limitations as a retrospective single center analysis. But as I say this, I will also say that the strength of that evidence is in the fact that the Mount Sinai PCI registry has been around forever. There are no exclusions. It's a collection of patients in a prospective fashion in terms of their outcomes, and the individual data collection that is unified across all of those patients. And we basically have looked at consecutive patients who present with a chronic coronary syndrome and undergo PCI with a drug-eluting stent between 2012 and 2022. This is a very large-scale database, and what we did is we classified them into high ischemic risk criteria, defined as at least one of those criteria that I already just pointed out, with a primary endpoint of major adverse cardiovascular and cerebrovascular events, which included all-cause death, spontaneous MI, or stroke. And then we looked at some secondary endpoints like stent thrombosis, bleeding events, because we also know that these same criteria, especially CKD or very, very high-risk patients, also have high risk for bleeding. So looking at the bleeding events and the individual components of MACE and target vessel revascularization was all there. And what we then did is stratify the patients according to the number of those ischemic criteria And we use Kaplan-Meier survival analysis and multivariate model Cox regression models to identify those individual predictors and independent predictors of events.
Great, thank you. Tell us the results of the study now, please.
Well, first and foremost, we had over 15,000 patients with chronic coronary syndromes who underwent PCI during this time period. The prevalence was quite high. Believe it or not, 71% of the patients had at least one high ischemic risk criteria, and showing how common these features are in our daily practice. Most frequent criteria were clinical, CKD and diabetes. And then there was a very, very important stepwise increase in major adverse cerebrovascular and cardiovascular events with increasing numbers of those risk factors, suggesting that the accumulation of those risk factors are very, very important and translate to progressively worse outcomes. And as I said, we looked at these independent predictors, and the independent predictors of MACCE was from the multivariate model was CKD, left main, diabetes, and a total stent length being greater than 60 millimeters. Interestingly, bifurcation using two stents and CTO were not independently associated with those MACE events. I just wanted to tell you the other major finding is this stepwise increase in bleeding risk every time there was a higher number of high ischemic risk patients. And most of those bleeding risks were associated with periprocedural complications rather than the post-discharge events.
That's an interesting point, actually, because the whole premise of assessing high ischemic risk is related to potentially prolonging the duration of DAPT. So given the greater risk of bleeding with progressive increase of high ischemic risk, particularly from periprocedural complications, is something that is important to know. So do you see then a need for a more refined scoring system balancing both, perhaps?
No, I think now, especially these days with AI and of course with machine learning, we're going to get to a place where the area under the curve is going to be a lot bigger for prediction and in fact even evaluating predictive models that are much, much more precise than what we currently have based on both clinical and anatomical factors, and then furthermore what we prescribe patients and helping us. So I do think that they're going to be very, very important. And I think what the other piece of this analysis that's also very important with these chronic coronary syndrome patients is, since a lot of the bleeding events were in the periprocedural events, it's also very important for us to refine our access, because the access in this group was mostly femoral, and the use of the radial access was about 1/5 of the entire cohort. So I think that could have a very important implication in reducing these periprocedural or early bleeding associated with the procedure, which has to do with the femoral procedure. And maybe we can even refine that even more, because once you start having bleeding, then you start having this overlapping risks, and then an issue with dual antiplatelet therapies and maybe worse outcomes. So it's really important to kind of pay attention to both procedural and non-procedural events as well.
I think that's a really important point to highlight, that radial was about 1/5 of the cohort, and that certainly probably had some impact on the periprocedural complications, as you have very correctly pointed out in the manuscript in the limitation section. Just another point about the proportion of intravascular imaging, which was relatively small, but interestingly, you found in this study that its use was independently associated with a lower risk of MACE. How do you explain that?
I mean, can you imagine that it was actually very low, but when we used it, it was so very important that it reduced MACE. And I think that's yet another very, very important piece that gives you the idea that use of intravascular imaging just makes you better, especially in high ischemic risk patients, better stent sizing, better expansion. detection and correction of stent malapposition, edge dissections. I mean, and maybe even not stenting things you don't need to stent, and the procedural optimization in both what to treat and what not to treat and how to treat and guide your treatment is really, really important and underlines the importance of how important imaging is in these patients with high ischemic risk. So I think this is really great. But even though the sample size was small, it still drove MACE to the lower level when you use IBIS and OCT.
I think this paper overall has shed so much light on such important factors of how perhaps we should do better PCI. And that is essentially the main takeaway for everyone in the audience listening to this podcast, as well as those who will be reading the paper. Do you have any final takeaways for the practicing clinician reading this paper, and what should be their takeaway?
Well, I think it's really important to think about not just high bleeding risk, but also high ischemic risk. And that was a very, very important piece that needs to come out, because they're both just as important. Not one should partake another. And I think that's very, very important. And when you do this concept of high ischemic risk is to help us guide our dual antiplatelet therapy duration and intensity. And I've always said less is more, but sometimes you understand that there's a major overlap between ischemic and bleeding risk. And the more high ischemic risk you have, the more bleeding you're going to have. And it's both. And you need to really understand how to modulate dual antiplatelet therapies. And there's no question that we need a much more refined scoring system for the future. And certainly, I think integrating even more granular data in ischemic and bleeding risk is going to help us guide antithrombotic regimens better. And I'm totally clear that in a very, very short period of time with AI and machine learning, we're going to get there. And I think that is literally should be the way we go for the future.
Fantastic. Thank you very much, Professor Mehran, for this important and relevant study and for discussing its nuances with us on this podcast.
And thank you very much for having me. And it always is a wonderful pleasure to be with you and to listen to your beautiful words. And thank you for having these podcasts to bring forth what these studies are all about. So thanks again.
Thank you for listening to Editor's Choice. To read the full article discussed in this episode, visit EuroIntervention.org. And if you've enjoyed this podcast, please subscribe to Editor's Choice for more conversations behind the science published in EuroIntervention.